heard. Okay. And I just wanted to quickly, before Dr. Andress starts, to just say thank you, Patient Care Work Group, and thank you, Dr. Andress, for joining today. Dr. Andress is a longtime friend of NIDDK and is very familiar with the patient-facing aspect of kidney disease care. And he currently works as an EHR technical lead for the Quality Measurement and Value-Based Incentive Group at the Centers for Medicare and Medicaid Services. Today, we're really happy to have him present on the CMS Digital Quality Measurement Blueprint. Just a little bit more about him. He's worked closely with the Yale core team and collaborates with partners at CMS and other federal agencies as a part of the CMS digital quality measurement transition in service to broader interoperability projects. And that work includes the implementation of FHIR-based reporting for CMS quality measures and the US CDI Plus initiative announced by ONC. So he works as a quality and cost measure developer for various programs at CMS and has been doing so for about 11 years. So before I turn it over, Dr. Abbott, did you have anything to say? If not, we can let Dr. Andress take over.
So I just want to say I'm very glad to have Dr. Andress with us. Always has very valuable and insightful things to say. So I won't detract further from his time. Thank you.
Thanks.
Well, thank you very kindly. Do you want me to start sharing my screen?
That sounds good.
All right, let me.
Yeah, you should be able to share.
Let me make sure I've got this right. Okay.
Yes, we see your slide deck now.
All right, and let me start the show. All right. Situated around. All right. Are you seeing the slides, or are you also seeing the control on that I have on the screen?
We see both.
You see both? Oh, okay. Well, that's inconvenient. Let me see if I can't.
Yeah, now we see. Oh, hang on. Yeah, now we see your slide in presentation mode.
Excellent. That is fantastic. Okay. Thank you for bearing with me. Of making an effort of trying to get that worked out, but frequently run into issues with it. Anyway, thank you for letting me join you. As Katya was noting earlier, I've mostly interacted with NIH in the past on issues around kidney care in my former life as a measure lead for the ESRD QUIP and dialysis compare reporting programs at CMS. The scope of my work now is, I think, considerably more expansive and is targeted toward looking to transition our quality measurement at CMS, and specifically our quality programs, to a digital format. And we'll talk a little bit about what we see that as meaning, because I think that there's a lot of room for wiggle on the what digital measurement can actually mean. Some people would argue that we're already using digital data, and to some extent that's true. But it's also true that what we've enacted so far hasn't really gotten us what we want out of the quality sphere. I think another key point to make here is, and I actually made this point on a call just before this, in talking with our colleagues in the post-acute care world at CMS, is that while we are in fact, we're focused primarily on our quality reporting programs and the infrastructure necessary to support those, and thinking about how we implement digital quality measurement within that context. We found it more helpful. I and the Yale team and others here at CMS that I work with have found it useful to start shifting how we think about the digital measurement work and focus less on how we get to digital measurement and more about how what we're doing in digital measurement supports the broader interoperability project. And I mean, there are a number of reasons for this. One is simply out of necessity and survival. The reality is not everybody cares about quality measurement. I know that's hard to believe, but in fact, there are some people who find other aspects of the healthcare system to be equally important. And I think in order to push for interoperability, we have to acknowledge the presence of all of those enterprises and their relevance in creating a learning health data system. And that can be a bit of a blind spot, especially at a federal agency that works primarily as a regulator. We tend to be governed very specifically by our federal statutes, by our mandates and regulations. And stepping outside of that, I think, has served us well, both in terms of broadening our understanding of what needs to happen in order to support digital quality measurement and how what we're doing in digital quality measurement can benefit these other spaces as well. So I appreciate the opportunity to speak here and hope to walk away from here with a better understanding myself about how what the work you're doing, about how what you're doing interacts with and can enhance what we're seeking to do, and vice versa. All right. So to get started on this, I think y'all are familiar with the evolution of quality measures, so I won't belabor the point. Of course, it hasn't been nearly as linear as this slide might suggest, but what it does reflect is an ongoing effort to get from the original manual collection of data to an experience that essentially digitizes the data we have and makes it readily accessible for a variety of uses in a way that is ideally instantly accessible and responsive to the particular needs of the data user. And that shift has been pursuing electronic clinical quality measures for some time. And in fact, a lot of our work right now focuses specifically on electronic clinical quality measures, less because we think ECQMs are necessarily the endpoint, but because we see the infrastructure underlying them as giving us an opportunity to build a model for how to shift other data sources and measures based upon those data sources into a digital framework that provides us the access to truly interoperable data that avoids a lot of the programmatic and infrastructural silos that we continue to encounter now. So a lot of our work has been built off of work that was either ongoing well before this, in addition to a number of recent regulatory requirements that have been put into place. So if you think about, you can think about these as sort of the underpinning of our approach to digital measurement. I think core and central to this is a pair of interoperability rules that ONC and CMS have finalized, which require the capacity to capture and then transmit interoperably a core set of data elements defined under the US CDI by ONC for two particular purposes. In one case, to provide those core data elements for certification, and in another to make sure that those data are accessible to patients and payers under the CMS rule. And essentially what this does, it lays the groundwork for saying we're defining a core set of data elements that have to be readily accessible, and it provides a specific mechanism, that is the use of FHIR-based APIs in order to make that available, in order to meet certification requirements, and in order to meet baseline interoperability requirements within Medicare. The value to that is that it creates a framework that we think we can build off of in order to expand it to build toward interoperability for a broader set of data than just what is defined under the US CDI version 1, which has carries with it a number of limitations that I suspect most of you are quite aware of at this point. And if not, I'd be happy to discuss it afterwards. We've also been undertaking efforts at CMS to prioritize specific areas of measurement, particularly in identifying ways to capture those data, the data relevant for those measures digitally, and then to make use of them in a way that is streamlined compared to what we have now, which tends to be clunky, burdensome, and has difficulty being responsive to the specific needs of providers outside of the particular need of submitting data to CMS for program requirements. We want to try to break out of that limitation of the data that we're using. There's an ongoing strategy project at CCSQ here in CMS to build tools for specifying and testing electronic clinical quality measures in FHIR, as we've been looking to adopt the new standard. And we've begun undertaking an effort to develop a unified FHIR server, which they are of course calling Unifier because we're creative like that, to serve as a centralized receiving system for FHIR data at CMS that can then provide those data to the relevant programs. And then finally, we're building off the effort of a number of HL7 FHIR accelerator programs, including the Gravity Project with social determinants of health, to start advancing FHIR standards for a variety of use cases, obviously, but specifically in our interest for quality measurement. So you already have a lot of work that's ongoing to that is consistent with where we think we want to go. So what are our goals in this project? First and simply, we want to develop a quality measurement system that's fully based on digital measures. And I'll talk a little bit in a moment on what digital measures are and how we're thinking about them. We want to use this as a means to reduce the burden of reporting while also, one, expanding our view into the quality space and making these data accessible for purposes other than quality measurement. So one of the primary limitations that we've encountered with our programs, and I suspect many of you are familiar with this, is that each individual program tends to have its own set of requirements. And then there is a cottage industry built around meeting those requirements. And every time a new program has a new requirement, it builds up and it increases the level of administrative burden within the system to implement those requirements. And it's this duplication of effort that has created, I think, a lot of the backlash to to quality measurement as a whole, as an enterprise, and continues to be a barrier to interoperable data for the healthcare system. We're looking to be able to leverage these measures to be able to get a better sense of what quality actually is, to break out of the boundaries that existing data systems like Medicare claims can impose upon us, and the limitations that those silos cause in terms of insight into patient care, access to resources, and other factors that frankly are limited more by the structural constraints of how the systems that support them were created than anything to do with the actual care that they receive. And then finally, we want to get to the point where quality data is essentially a consequence of care rather than an administrative burden heaped upon that care. And so this blueprint is really that I'm going to be talking about here is really kind of our conceptualization of how we can start down that path. Excuse me. So to speak a little bit about digital quality measures and how they're defined, I think I'm taking a little bit longer here than I intended to. The concept of digital quality measures really breaks down into two pieces, and there's some more detail here, but those two pieces are essentially that the data are captured within a digital format and can be stored and transmitted accordingly. And secondly, that we have the technology and infrastructure in place to be able to render those data interoperably across systems. So it's not just a question of what data they come from or how the measures are specified, but it's also the context in which they are captured, transmitted, and stored. That is a system that is designed to operate interoperably across platforms, across settings, across providers. If you don't have both of those, you don't really have a digital measure, even if the data are captured digitally. And so our focus is trying to get, a lot of our focus is trying to get at the data elements that we need to ensure that they are captured appropriately, that we have the infrastructure in place to be able to transmit them, and that we have the processes and resources in place to ensure that those data can then be used after they have been transmitted in a way that's effective across a wide variety of needs and use cases. And that's really what comes down to the learning health system. And I'll give credit here to Maria Michaels for sharing this with us. We actually stole this from her presentation, which I believe she stole from someone else who had where she'd found it, and I think it kind of lays out quite nicely the what we're really gunning for, which is to say a system in which the data that we capture serve a wide variety of purposes and uses, and it's therefore agnostic to any particular program's requirements, and rather the program's requirements are built off of the data we need in order to create a learning health system. That is a system that's capable of learning from its experiences in a wide variety of contexts. So in breaking out our blueprint at CMS, we identified at a high level 4 domains of action that we believe we need to undertake. And these center around the standardization of data and the enhancement of the quality of the data that we're capturing, leveraging technological opportunities that we've identified, including FHIR, optimizing the means by which we are able to aggregate data for purposes across platforms and settings, and then finally ensuring that we have alignment. And this really, Grace, just to note, I think this is something we actually need to update on the slide. We say measure alignment here, but what I think we've really started talking about more is data alignment, because the measure alignment is fine, but as I said, a lot of this really grows out of the data elements that you're capturing, and because of the granularity that I'll be talking about here shortly, much of what we're seeking to pursue in terms of measure alignment is facilitated on a more fundamental level by alignment of data elements and data element standards. So in talking about the standardization of data, we can really break this down into 2 pieces. First, we have the consideration of the standard the data standards that that the data elements are captured in. Of course, we're looking at FHIR because of the flexibility that it contains. It allows us to capture data or map data across a wide variety of other standards and make use of those data in a common format, which is important because it allows a variety of systems to then be able to predict accurately what the data they're going to be receiving is. That's obviously quite key to this. but we also mean standardizing what data can predictably be relied upon to be present within a healthcare system. And this, the relevance of this will become evident momentarily. But we know that clinicians and payers and researchers and others reliably need access to certain kinds of data in order to be able to undertake the work that they do. And part of what that means is we need to be able to identify as best we can what those data are and ensure that they are the data that we are capturing interoperably in a way that can be consistently shared across the platforms. So it's not just a matter of having a common standard for whatever data elements happen to be within your system, but defining what data elements should be accessible within the system to begin with. And so to that purpose, we've been engaging with ONC's US CDI process. We've done so first by submitting our own recommendations for both version 2 and version 3, identifying what we think are data elements relevant to our quality measures, but that also we also believe fit comfortably within the heading of supporting interoperability as a whole. Some of the examples that we've submitted here previously have included social determinants of health, have included medication data, encounter information. One of the things that we encountered in sort of the initial run up to our participation with the US CDI is that when we talked with ONC about this, there was about what was included in the US CDI, what their vision was for it. There was this discussion about having the core clinical data elements in it, which is fine. You need core clinical elements within it, but the reality is, from our perspective, and as we talk with more people, I think for most users of these data, you actually have to have a fair buildup of administrative data, data that provide context around these the US CDI data elements that have been identified in order to be able to make use of them. For a quality measurement, you have to be able to define attribution. You have to know who did what, where, when, what the context was for it to be happening. And so this meant that we began to contemplate a broader set of data for US CDI, I think, than US CDI had used, which was inconvenient in some ways because we'd been hoping, at least initially and quite naively, that we'd be able to use US CDI and the mandates surrounding it in order to define what data we needed for quality measurement and ensure that it was broadly available. Of course, life didn't make it that easy. And that's why we've been talking with US CDI about US CDI Plus, which is essentially an effort to define in I think an aligned and common fashion different use cases for which data are necessary and for which common standards and requirements need to be laid out, but that doesn't necessarily fit within that core definition of what is in US CDI. So US CDI Plus then is essentially an effort to, from our perspective, to supplement what is in the US CDI to meet specific use case needs. And the effort and the work that we've been undertaking with ONC on this is have served dual purposes. One is for us to be able to identify what data elements we want to incorporate within certification requirements that specifically serve our quality programs. But we see that as sitting within a broader use case for quality measurement that is not defined solely by what measures we happen to have in our quality programs, but needs to be defined more broadly. I mean, we're currently working with federal partners to identify what that actually needs to look like. And of course, we're all starting at the point that we're familiar with, which is what our own requirements are. So we're trying to get a picture of the landscape as it currently exists. But even that is only But even that serves a dual purpose in that we're looking to use that process as a model for building out essentially requirements or standards for all of the other use cases that exist within the realm of interoperability. So care planning, which I think is the focus here, would be one potential example for that. But you also have CDS, you also have public health, you have a variety of prior authorization, you have a variety of use cases for data standards that are needed, and we need to build out a process for defining those and maintaining those definitions in a way that can then be disseminated throughout the healthcare data ecosystem. And so that's really what we've been in the beginning stages of pursuing with ONC and with others. I think what we'll find is that this is really just the early stages of that, and there's a lot more to go, a lot further to go than even we realize at this point, if only because that seems to be how everything goes in the federal government. The second domain that we're focusing on is technological opportunity. So FHIR APIs offer us the opportunity to pursue a model of quality measure specification and data transmission that we haven't necessarily had access to before. It allows us to consider multiple data sources that use a variety of data models and standards, but that can be mapped to FHIR as a common, to serve a common data source for specific use cases, for program needs, for measurement specifications across use cases. So it's not limited only to quality measurement, of course, and that's really kind of the value that we see in this, because while it does serve our purpose, it's not only serving our purpose, and that's one of the core limitations that the QDM has had for us in pursuing ECQMs in the present state. So this is a rough model of how we're thinking about this working. And it really starts with defining the specific roles that we see in place for the EHRs, and then for the data customers or users at the end state. So we see this as an exercise for the EHRs primarily in capturing data, mapping those data to the FHIR standard, and then producing distinct defined API endpoints. Currently, the way these are defined within regulation is through the US CDI content. But what we would see but part of what we're trying to do with the US CDI Plus efforts, and can be supplemented through program-specific requirements, is to further define exactly what the required endpoints are for interoperability, because you can define what data elements need to be collected, what the constraints are for those data elements, and how they need to be made available to serve a program's needs. The limitation for this, or not limitation, but the caution for this is that CMS can go and define these fairly readily. I mean, we have to undertake the mapping process ourselves to define what the data elements are, but we can define, and in fact have for the most part, the data elements, the discrete data elements we would need in our measures. So we could just build a certification model off of that. The problem is that it's defined solely on our requirements, and then we potentially block off, particularly if we're driving a significant amount of vendor development, we're potentially blocking off all of the other opportunities for interoperability. And that's why the engagement and later on the alignment that I mentioned, and we'll discuss later, is so important to this project, because this can be done for a single purpose, but we really want to be doing this for all purposes. But the value in this is that once those API endpoints are rendered within an EHR, they are accessible for use by by data users and customers with the permission to do so. So this could be CMS, and in fact, for our models, we're generally thinking of it in that way. But it can also be for third-party registries. It can be for other providers where data sharing is necessary in order to coordinate care. It can be for states. It can be for private payers. The data are rendered available for a variety of purposes. And because the data elements are defined discretely, you don't necessarily have to tie them to a particular use case in order for them to be accessed and then used, as long as you've undertaken that previous step of setting up the data standards in such a way that they are able to support a variety of use cases at the starting point, which is why we need those data standards in place, because otherwise you can't necessarily guarantee that the endpoints you're getting are consistent across the board or from EHR to EHR. So then that brings us to the question of what do we then do with the data once they're available in the EHRs? And that brings us to a concept that we've been working on in CMS called the measure calculation tool, which is essentially just programming code that implements the measure logic to process the data, produce an appropriate report or series of reports as defined by the user's needs, and is then able to do something with them, like transmit them to providers to share them with another system. But because the tool itself is essentially an engine, it's able to be adapted across multiple. It's able to be adapted across multiple purposes. So you can build a tool that serves this purpose for multiple measures across the board. But you can also build tools for other purposes too. There's no reason that what sits in here has to be specific to a CMS program or has to be specific to a given project or a given measure. Essentially, anyone who has access to the data can build the tool to make use of the data in for whatever purpose they need. And as long as the data standards serve that purpose, theoretically at least, you should be able to use those data for that purpose. And that means you don't have to recapture those data. You don't have to capture them in a certain context as the provider. You don't, each time you need the data, you can capture the data and then use them for all purposes. So this gets you to a point where data are atomized. They're in a common standard, even when they're from different data sources. And that brings out the opportunity to combine those data. So we were talking about data silos before, and the fact that data systems typically are defined by the specific purposes that they serve, which means they carry the limitations of those purposes. And that means that we end up with siloed access to information that may actually be far more broadly useful than we are currently able to take advantage of. And the accessibility of multiple data sources on a common standard would give us the opportunity to begin aggregating these data and then using them for multiple purposes to get greater insight into a broader set of information than we previously had. Social determinants of health is an obvious example of this, but of course access to care across settings, where currently a lot of our data are segregated through program or setting specific data sources that no longer necessarily needs to be the case. It makes it easier to track patient care and outcomes across settings over time. It also makes it possible for some of these multi-organization entities like ACOs to pool their data across those settings more readily for their own internal programmatic purposes. And these are some of the things that we're hashing out about how this would work. It's not without its issues. You have to define rules governing how these data can be matched together to deal with deduplication. And these are issues that are present now and are not solved directly by FHIR. So you have to have in place underlying policies about how to match the data. The advances that we're talking about now simply give you the opportunity to more readily transmit those data. And so, you come across some of the issues I'm sure a lot of you are aware of, like the banning of a universal common identifier for patients, the difficulty in matching patients up against or matching patients statistically or probabilistically with one another or with their own records across different settings. And of course, the difficulties introduced by missing or erroneous data. So this doesn't solve all of our problems inherently. And I think this is part of what we're going to have to work toward resolving, as part of getting to a future state where these data are readily accessible. But it gives us the opportunity to do so, I think, in a way that we haven't had previously. And then finally, there's the issue of alignment. Alignment is a lot easier if we're working from a common data source. And that's really what we're talking about trying to create, is a broadly accessible common data source where there aren't the same silos blocking off our access to the data simply because they're built for different purposes and different times or for different settings or to come from different sources. And that's fantastic in that it gives us an opportunity, but of course, the alignment still has to happen. And as I alluded to before, it's not just a matter of creating alignment on the measures that you're using, but it's really creating alignment along the data elements that you're capturing and the information at that granular level that's being incorporated. It is possible, I think in fact, I think we expect that different users of specific kinds of data have come up with different ways to collect data, the same kind of data elements in their programs, or at least related data, which means that you have misalignment in those. And we know that that's the case in quality measurement, and it will be, I think, none too surprising to find it across use cases with which we are not currently familiar at CMS. And part of the work we need to undertake is to align our data needs across the use cases as well as within the use cases. And that is fundamentally an exercise in bureaucracy, an exercise in negotiation, and an exercise in compromise that doesn't get resolved by technological advancement in and of itself. So I see this in many ways as this being the hardest part of what we need to do. And I think we need to start putting together the framework for how we can resolve the inevitable misalignments that we've built into our system as of yet. I think US CDI Plus is one opportunity to do that. I suspect it's probably not enough on its own in its current form. One of the things that we've encountered in discussing this project with others has been the need for a partnership with private entities, not something that CMS is terribly good at, particularly where it relates to implementing rules and regulations. And so that's something we're trying to learn more about, how we can incorporate that into our digital measure transition in a way that adheres to the rules and laws and requirements around rulemaking and program implementation, but also allows us to get the alignment and participation from the private sector that we need to help inform our decision making. And that actually just covers the slide, so I'm going to skip over the next one, which gets me to your initial request for us to come speak here, which was how does care planning fit into all of this? So when Jenna contacted me and asked us to present, we asked for some time to get in contact with some folks here at CMS about how we've been thinking about care planning within the context of this. And we took some time to do that and found that we really didn't have a good sense of how it fits. So part of what I see this as being is an opportunity to kind of talk with you about what we're doing and also get a sense for how it potentially fits into the work that we're undertaking. Now, I think in talking with Maria Michaels about the work in CPG on Fire and how she sees the clinical guideline development fitting with care planning and quality measurement. I think, there's, I think we tend to agree that that's a good point for connections, but I suspect there's more to it. I think we want to, I think we want care planning to be reflected within the US CDI Plus work that's ongoing, because it's going to be, I think, one of the more important use cases that we in quality measurement can link to. And I also think it's one of the areas that we've had the most difficulty linking to, because our work tends to be viewed as administrative burden rather than clinical contribution. And I think that's the fence we need to jump from a quality measurement standpoint, where what we're providing has a clear pathway to improving the care that patients receive, not just from our perspective, but also from the perspective of the clinical care providers and the guideline developers in our system. And so I think there are a lot of opportunities that I can think of to get involved in, but I'm not familiar with how you've engaged with the interoperability work in a broader context yet. And so I think what I think would benefit us from our perspective is to find out what y'all are doing, where you see the opportunities for engagement, and to find out how we can help each other to meet what I suspect are mutual needs for data standardization and interoperability. So I will close off my pitch there and turn it over to you, apologizing for taking longer than I had initially planned. Thank you.
Thank you. This is great. Can you hear me okay?
Yes, I can.
Yeah, I like this slide. I like your first two bullets. One of the things that come to my mind is the managing of ongoing care is, to me, care planning, dynamic care planning, at least care planning in real time, will assist the clinicians in identifying gaps in care, preventing overuse, you know what I'm saying? Redundancy in care, things like that. It will probably increase patient satisfaction. You know how, a lot of times patients complain about they get asked the same questions over and over and over again, or they get the same kind of treatment, even though they just had that test, they get the same test done. So those are all some of the things that we're hoping, or we're thinking that implementing dynamic care planning in real time will help to achieve.
So I think one of the big complaints about quality measurement is how untimely the data are.
Yeah.
And sometimes that's actually intentional, right? With CAPS, they designed it so that providers don't receive the data, or receive the data in an aggregated sense, so that they can't identify the reporters, because they found that people reporting the data were more likely to provide lower scores if they knew that their providers weren't going to know it was coming from them, which is an interesting conundrum in and of itself. But getting back to the point, it's an issue of how quickly can the system provide data, and the answer is not terribly. In fact, most of our data, most of our feedback comes back on an annual cycle, maybe a quarterly cycle, but with some 6 to 12 months of delay in providing it, because that's how our systems currently operate. One of the things we've talked about in the context of, let me look this up, right, the MCT, is that you could potentially develop a measurement tool that pulls in the data and then spits it back out. Or you can develop a tool that is used in the CMS system, but can also be mounted alongside the EHR, and the providers can then make use of it to run their own data and produce their own reports as they see fit. So they don't necessarily have to sit around and wait for CMS to process the data in order to get some sense of how they're performing. There are some limitations to that, particularly if you're using data that they don't have access to. Risk adjustment comes to mind, right, for claims data. But it gives you a mechanism and an opportunity to get feedback quickly, at least far quicker than we're currently able to offer. So this seems like there's some opportunity there. I'm not sure I understand what goes into real-time care planning enough to be able to say exactly what it is, but it seems like it's something we could investigate.
So Joel, this is Jenna. Thanks so much for coming, and I apologize, I was a little late, mostly because I just lost track of time being on parental leave. But the part of your presentation that I did see was great, and I wanted to speak to some of the questions you had at the end, and talk a little bit about the degree to which we focused on data standardization, which is, at least from the perspective of our MCC eCare plan project, that's been our primary focus. So we're not even getting into yet the like CPG on fire kind of space yet. We're not getting into the clinical guidelines space yet, in the sense that we're not actually, focused on making the recommendations computable. We're actually trying to get all the data, all the pieces of data that we need, and make sure that those are able to move across settings. And we've been relying on USCDI, as you suggested, and our plan has been to submit data elements in a future phase coming out of our work to USCDI. We're also, aligning with others working in the sort of standardization space. So Gravity, who's working on social determinants of health, and PASIO, which is, a CMS project you're probably aware of, focused on acute care standards. So I think we've very much been thinking about the standard space. And I think the point that you made is exactly correct, and part of the reason why we wanted to have you here is that we can't have different standards for care planning and then a complete different set of standards for clinical quality measures, and then a different set of standards for something else. So just trying to make sure we're aligning across these spaces, I think is really important. So I'll pause there, but
Jenna,
thank you for coming in.
If I can ask one question, are you involved in the USCDI Plus initiatives? So you mentioned USCDI.
No.
What about the USCDI Plus? Okay.
No.
I would like to get y'all in touch with Beth Myers and I think Alex Baker. Well, actually, let me go talk. But I mean, Beth Myers, Alex Baker, and Rob Anthony over at ONC who are driving that initiative.
That would be great.
Yes, thank you.
Yeah, in talking with them, I think there are a couple of things to be mindful of. One is that part of the reason that we're modeling the approach for building the USCDI Plus use cases after quality measurement is because the nature of quality measurement requires that we have tightly specified data needs. So that means we have ready access to this. And one of the things that ONC's mentioned to us is that there's actually a broad range of preparedness to provide that level of detail in measuring out these use cases. So I think we've been pulling in people to the USCDI Plus who are at varying levels of readiness. And Maria is part of that, and of course the CDC has similar needs in terms of how they use data, so they're pretty sophisticated on how they're thinking about this. But regardless of how much detail you've gotten into identifying specific data needs, I think being involved in the discussion gives you an opportunity to see what's happening and get a sense of how we're trying to go about specifying it, and think about how the implications of that for your own work, to see where it may overlap or where it may need additional specifications, and how to go about communicating that. As I say, we've spent about the last 12 months, about a year now, trying about 9 months in total to try to get to a format where we could give ONC the information we needed. So that was painful, but it was also necessary in order to be able to communicate with them effectively what we thought certification, and by extension, the quality measurement use case of USCDI Plus needs to be, or needs to look like. And so then we're able to start providing them with the information. So I think that's that's an administrative constraint because not everyone thinks about it in that way, in that context, and it gives you a vehicle by which to actively pursue the kind of data standardization we're talking about. So yeah, let me write that down. Who should I get them in touch with? Was that go to you, Jenna, or is someone else covering for now?
Sorry, it took me a second to get off mute.
Kevin Abbott here.
Yeah, Kevin Abbott is my I guess he's the core on our contract and can help move things along. Joel, that would be great if you could include me too. I just might be slow to respond in the immediate weeks, and then perhaps also if you could copy I don't know, Katia or Evelyn from EMI as well, from our contracting team. That would be good as well. Evelyn Gallego or Katia Shell.
And then, go ahead. And then I'm probably going to say Karen as well as their project manager.
Yes,
Thank you.
Joel.
You have Joel's emails. You can just send him all the people you'd like to CC. I think.
Sounds good.
Yes.
Yeah, that's fine. I've been accruing quite a list of contacts for a variety of federal agencies. My VA list is already makes my head spin at times. But yeah, anyone you want included on the conversation, I think we can pull you in. I think the next meeting they're planning to have is in January, which is time to come out around the time they're publishing the draft version 3 of the US CDI. So as a heads up, I think that's likely when it gets rolling in directly. But there isn't anything that necessarily stops us from talking about our ongoing process now. And in fact, we're planning on having, I think, at least one more meeting before the end of the year on the certification spreadsheet work that we're doing to identify quality measurement use cases. And if you all would be interested in be on that conversation as well, I think that's fine. Just note that that's more targeted toward quality measurement than to other use cases right now. So if you're participating, that's going to be the focus of the conversation.
So Joe, if I could ask one quick question. So maybe it's wishful thinking, but I think many of us on the call have been thinking if there's any agency that can get different EHR systems to work together, it would be CMS. Is that kind of a pipe dream, or do you think there might be something to that?
I mean, you were here for Medicare.gov, right?
Oh, yes.
So there is actually a specific use case for this within our particular program that this is actually I think an issue of some priority, and that's the ACOs.
Mm-hmm.
To a lesser extent, the MIPS program in general, but primarily the ACOs, because they have a lot of issues with aggregating data across the individual participants in their organizational structure. Because frequently they have different instances of platforms, right, or just different platforms entirely for their EHRs. And they've had a tremendous amount of difficulty in trying to resolve this. So we actually just had a meeting here fairly recently with ONC, where ONC suggested some changes to the QI core IG in order to alleviate that, and in terms of requiring the TIN and NPI data fields. So we're looking into some potential modifications to there, but I think that really only gets us part of the way. It's not really tied to FHIR implementation, but that's really where I was getting into this issue of data aggregation, where even if you have the technology to share the data, you have to be able to resolve the data, right? You have to be able to deduplicate it. You have to be able to make sure you've got patients matching, and that patient matching algorithm matters differently for different use cases, right? So quality measurement, I mean, a 95% match rate's probably fine. It's not perfect, but you can live with it. If you're doing care planning for a particular patient, on the other hand, you really want to make sure that you've matched the right patient data to the correct record, right? And so it becomes more critical to have that particular match. So yes, I think CMS is going to be thinking about how to do this appropriately for our EHRs. I'm not sure that a solution that works for EMS or CMS quality measurement necessarily works for all of the other use cases. I think it's probably worth thinking about how to implement that kind of a thing in the process, right? To make sure that you're able to serve the different use cases. So while we can standardize the data that you're looking at and what's available, the standard you're applying to say this record matches, or these records match, I think is not something that's been well defined at all across the board. And I don't think there's any particular standard or agreement toward it. So although that's a long way of saying yes, that's something we're interested in doing. But no, we haven't figured out how to do it in a way that's necessarily portable to everyone else. And really, frankly, we're still trying to figure it out for ourselves. So we're currently talking with the ACOs and some of the other APMs teams about implementation of FHIR-based reporting for ECQMs in the next 5 or so years. And part of that discussion is around that, moving toward beneficiary level data and then using those data to be able to match across platforms, which they've identified as a core need of their program.
Right, we are at time, but I see that there are 2 hands up, Maria and also Shelley. So are we okay to extend for a couple of minutes so therefore we can get those 2 hands up questions asked and see whether or not we can address them? So Maria, Joe, are you okay to stay on for a couple more minutes?
Yeah, this is Shelley.
Yes,
sorry, Joe, are you okay?
Stay on. Yeah. I can stay on, and if we don't get to, if we have other questions, obviously, you'll have my email. Feel free to distribute it, and I'd be happy to hear any other questions or concerns that y'all may have.
Okay, thank you. Maria, you're next.
Yeah, Joel, I know how to get in touch with you. So mine's more of a set of comments, and it started with Emma's comment a while back. But what we've done, in fact, right before this call, we also had a call focused on CPG on FHIR, where we were talking about the care plan as it's defined in CPG on FHIR. And we're planning to pick that discussion back up on November 11th, which will be a call right before this one again, if you guys are interested in joining that. While I know, Jenna, you guys have been focusing on the data elements, I think both together are really needed in terms of defining how you would put those data elements together in a care plan, and that's what's in CPG on FHIR. The other thing I'll say about what's in CPG on FHIR is that we really worked across a lot of different experts to do a little bit of what Joel described in his presentation with respect to other areas. It's not, like you said, not just quality measurement, but care planning, obviously, public health reporting, other research, other areas that essentially are trying to do the same type of thing with respect to getting data from these different digital data sources. So we've basically built into the CPG on FHIR specification a way to do that, somewhat focused on guidelines and recommendations, but really any type of knowledge that you're trying to make computable, and ways that you can reuse that information for the other types of knowledge artifacts that you want to create, whether that be things like decision support, quality measures, care plans, case reports for public health reporting, for research, and so forth. So just, I guess, keep that in mind, and I think we would be happy to have joint discussions at any point in time if this group wants to either join the CPG on FHIR group, or we could join this one occasionally, that kind of thing. That's a subgroup of the CDS work group, by the way. And then the other thing I was going to say is, I know, Jenna, we haven't talked about this in a while, but I've recently been talking to Joel and team about our MedMorph project that's making EHR data more available for research and public health. It started with a little bit more of a focus on research and public health and EHRs as the data source, but the intent is to expand beyond that to additional data sources. And that can be a way to exchange the data from those data sources to whatever endpoint they ultimately need to get to, including potentially populating a care plan. So that's another area that we can continue discussions on. And I'm happy to give more information on those if you guys would like, but just wanted to point those couple of things out that have been in the works that do start to move towards all of the things that Joel really well defined in this presentation.
So before we move to Shelley, I just want to respond to your comment, Maria, about the connection with care plan. This group is working on the care plan domain analysis model version 2 or release 2, and in which we are focusing on a number of areas. One will be social determinants of health, goal and goal measure and outcome, and also in one topic will be looking at how to address gaps, how care plan can contribute to addressing gaps in care. So in that context, I think the care plan project work would like to have a more frequent connection with your group and also with Joe's work in the quality measure data. So I would appreciate a more frequent interactions between you guys and also and Joe's work. So therefore we can see how we can collaborate and make sure that the quality measures are being seamlessly addressed in the care plan standards design. So that's sort of my sort of a couple minutes spiel on that. And before I move on to Shelley, just excuse me for just a couple more seconds. Joe, can you make your slides available to us? We would like to sort of, if possible, make it available to the care plan project team who are not able to be here today.
Stephen, I did post them on our eCare plan site, and if there are updates, Joel, you can just resend them to me.
Wonderful.
Right. Yeah, okay. This is a very condensed version of the slides that we put together. I can share with you a more expansive.
That would be wonderful.
A more expansive set as well with some more detail.
That would be wonderful. Sorry, Sherry, do you still have a question that you want to ask?
Sure. This is Shelley Fire with
I'll fix it and I'll take you out.
Sorry, awfully noisy. This is Shelley Fire with Pharmacy HIT Collaborative. We have implemented the pharmacist electronic care plan nationally for a couple of years now. That is extended into thousands of different independent community pharmacies throughout the United States. But what we did through the Pharmacy HIT Collaborative, we standardized the codes that are being captured within the pharmacist electronic care plan, and those codes are in value sets in the National Library of Medicine's Value Set Authority Center. And now we work with the Pharmacy Quality Alliance. So Joel, I put my email in the chat directly to you. So we might want to connect, and let me connect you with the quality measures, because they already started to work on quality measures for pharmacy through the Pharmacy Quality Alliance related to the clinical documentation that pharmacists are capturing in the pharmacist electronic care plan.
Okay, certainly. I think that would be good to see. I guess in terms of what you're capturing, so you're capturing data elements that are in the pharmacy, in the pharmacist care plan.
Yes, the pharmacist electronic care plan captures all sorts of interventions and outcomes, goals, social determinants of health, just a huge amount of information that is being captured by pharmacists, especially those in the independent community pharmacy sector nationally. So there are programs nationally across the United States where they're using a FHIR version of the pharmacist electronic care plan and are capturing that information. We've been working with the Pharmacy Quality Alliance which is the organization that makes the quality measures for pharmacy.
And that's using, so those have been designed using the QDM, I'm assuming, is that right?
You'll have to, I mean, I can get you in contact with the Pharmacy Quality Alliance. They can tell you more on the quality side, which measures they're working on, and they're publicly available on the Pharmacy Quality Alliance website.
Okay, that would be helpful. I think one of the other questions we'd probably have for them, and I'll follow up with you on email, is what, if anything, have they done in terms of thinking about FHIR conversion or mapping for those data as well. But I'll follow up on email and we can talk then, I think.
Sure.
All right, thank you very much. We for the wonderful presentation, Joe, and also for everyone's contribution, very much appreciated. We are way over the allocated time. I would like to, on behalf of HL7 Patient Care, thanks everybody for contributing, and also in particularly Joe for the wonderful presentation today. So we will most certainly want to keep in touch and collaborate moving forward. All right.
Thank you for having me. I appreciate it.
Yep. Thank you. So
Thanks, Joel.
yeah, okay, so we'll end our call today, and without any doubt, we will collaborate and looking forward to work together and further interactions like today in the future. Thank you.
Thank you.
Bye.
Take care.